All right, well, good morning. I'm really glad to be here. I'm very honored, and it looks like it's a wonderful set of co-presenters, and I'm very privileged to join them and to join all of you here today. I'm going to talk about racial discrimination and health inequities, and I want to take as my point of departure this whole issue of inequity. And so the first part of my talk is really going to be connecting health equity and issues of health equity to thinking about discrimination as a very fundamental way to think about it. And then as we talk about discrimination and racism, I want to adopt a multi-level and a life course perspective in thinking about this. So as your dean mentioned, we see disparities in lots of different outcomes, and as he suggested, there's a 10-year gap in terms of life expectancy between an American Indian baby and a white baby here in Minnesota. And these inequities we see in so many other outcomes, not only in infant mortality and life expectancy, but also in things like renal disease, heart disease, and many other health problems. And it's because of these large, persistent inequities in health that our nation's health planning document, Healthy People 2020, has made it a primary goal to not only improve the health of our nation, but also to reduce these inequities. But in thinking about reducing inequities, we can't simply improve the health of the population, cross our fingers, and hope that everything goes well. And in fact, what we really have to do is we have to recognize and fix the historical and contemporary injustices that are rooted in a racist society. And so that is embedded in our nation's health planning document. So, or to say it a little more succinctly in the words of Paula Braveman, equity means social justice. And there's been a long-standing and sustained scientific interest in studying discrimination. And so here, discrimination is definitely a civil rights and moral issue for all of us to grapple with, but it's also an important scientific issue because it's very plausible that racism explains these inequities that we have. And so rather than run away from the problem because it's politically uncomfortable, we have to address it head on. And so many important scientific bodies, such as the Surgeon General's Office, the World Health Organization, the Institute of Medicine, NIH, the American Public Health Association, et cetera, have really talked about and tried to understand how we might think about racism and how we might measure it and what's the basis of the empirical evidence that might pull all these things together in terms of health. And I want to couch this in a broader understanding of the production of health and well-being. So this is something that might look familiar to many of you. It's the work of Bronfenbrenner that many have adopted. Really this idea that health is not only based on what you eat or how much you exercise or all those things that you do at an individual level, but it's also fundamentally important in relation to your social networks, your friends, your family members, et cetera. It's also a matter of where you live, where you work, where you play, and where you get health care. It's also a matter of what's the social climate around us, what's the political climate, and what is the nature of the economic system that we live in, our point and our moment in history, the laws of the land, and many other things. So here, these concentric circles basically represent that there are many layers that are expanding beyond an individual person that contribute to their health. And we can think about inequities at all of these levels in terms of producing health and well-being. And we can also think about racism at multiple levels as well. And a lot of this is based on a lot of work from Black scholars and many others who have really thought deeply about racism. And so if you go back to, for example, Black Power by Carmichael and Hamilton, they provided the fundamental insight that racism operates at the individual and institutional level. Many other scholars since then, such as Kumar Jones, have talked about racism at many levels. And I think it's useful as we think about racism not to think of it only at one level. And certainly today, there's a lot of interest in many universities like UCLA and maybe here as well on things like microaggressions, which are certainly important. Okay, these are day-to-day experiences, but we should not stop our analysis and our interventions only at that level. And so if we can think about these other levels, we can think of these everyday experiences, as I just alluded to, and as we move through those concentric circles, we can think of racism also operating at, for example, the utilities that people might have access to, their access to care, where they live, and other broader things such as immigration policy. And I'll say a little bit more about each of these as we go forward. So at the individual level, we know that stereotyping happens. We know that people feel that their cultures are appropriated, right? And so there are many of these day-to-day interactions that people would consider to be racial microaggressions. And sometimes they're very blatant, and sometimes they're much more subtle and hidden. But people of color face these experiences every day on a day-to-day level. And the theory goes that all of these experiences are ultimately stressful, and we understand from a century's work of research on stress that stress can kill you, right? And so research is documenting that these day-to-day experiences of discrimination are related to stress, which then is related to various kinds of morbidity. And so an example, sorry, the fonts are a little off here, but these are data coming from the National Latino and Asian American Study. What you have here on the x-axis are a variety of health problems. So you have things like clinical depression, you have problems related to, say, chronic pain, respiratory problems like asthma, et cetera. Okay. The light blue bars represent people who report very little discrimination, and the dark blue bars represent people who report discrimination a lot. Okay. And basically, if you look across all of these health problems, there's a consistent dose-response relationship such that people who report more discrimination suffer from more morbidity. And this is a nationally representative sample of Asian Americans. These are controlling for things like poverty, age, acculturation, and all those other good things. So here, we can understand that discrimination is toxic for many populations across the United States. Oftentimes, we do think of racism in terms of affecting African Americans, but Asian Americans and many others also have to deal with these issues. Okay, and this little bit of work joins a much broader spectrum of research that ties experiences of discrimination to things like outright death, mortality. It ties it to biomarkers like C-reactive protein, and several meta-analyses. I think now there have been about 6 meta-analyses that have been performed over many years that have basically arrived at the similar conclusion that people's day-to-day experiences of discrimination are indeed related to various kinds of morbidity. Now, if we take a step back and we look at other levels of discrimination, so we know, for example, that there's been a long history of segregation of basic utilities, and even though we might say today that de jure discrimination is no longer a big deal, we might think about it at different levels, and certainly the experiences of the utilities service in places like Flint, Michigan have much room to be desired. And many people have said that what's going on in Flint is an example of environmental injustice. Okay. Now, part of what's going on here is that race shapes where you live. That people live in segregated communities is simply a social fact. But what do we do with that observation? I think an important reason why segregation is important is because it shapes your ability to access resources, and it shapes your exposures to environmental toxins like lead. Okay. And certainly, many people have talked about the role of segregation, including Tom Levis, David Williams, and many others. I think an important thing that Devin Payne-Sturgis and I have been thinking about is that segregation not only shapes your exposures to things like lead and other physical stressors, it also shapes your exposures to psychosocial stressors. And actually, in a hypothesis we've been raising, it's that the combination of these exposures actually amplifies the effects of each other. And I can talk about some of that research in the Q&A in case you're curious. But I think it's an interesting hypothesis that we don't look simply at single exposures, but we take a cumulative risk and a multiple exposure perspective, and thinking about how these social and physical and biological mechanisms work together. Segregation is not only related to individual persons' experiences, although it certainly is. right? So where you live determines, who you bump into and your day-to-day interactions. But segregation also occurs to institutions like hospitals. And so there's a whole body of research looking at the segregation of social services in terms of hospitals, nursing homes, and things of that nature. Okay. And now to take even a further step back, in those concentric circles that we have, another way that we segregate people in the United States is not simply where they live, but whether they can come here in the first place. And so we have talked about literally erecting borders and walls around the United States and about deporting people who are already here. Okay? And these are not new issues. And in fact, one of the first groups to encounter segregation of that nature were Chinese Americans. So in the late 1800s, the Chinese Immigrant Exclusion Act basically was an act passed by Congress, signed by the president, and upheld by the Supreme Court. So all three arms of the government sanctioned such discriminatory practices. And these conversations are very much alive today, certainly in terms of who we want to admit into our country, who we don't want to stay in the country, and all those things. And even though we might say, oh, well, we're not segregating our utilities like drinking fountains anymore, some people are suggesting that we need to still segregate things like parking lots. This work on discrimination is important not only intrinsically, but it also helps us reevaluate the ways we think about other important factors that are related to the production of illness. So to give you an example, think of the research on immigrants. And we generally, bless you, in the research on immigrants, right, a key construct that's used a lot in public health is this issue of acculturation. And the idea is this, right? Immigrants come to the United States and they become more Americanized somehow. Right, so we pour the American Kool-Aid into their brains, and suddenly that changes their health profile. Okay, and one of the ways that we think about measuring acculturation in public health is really years in the U.S. The longer you've been here, then the more exposure you have, et cetera, et cetera. Okay, but let me give you some other data that might help us rethink this. So these are Asian American immigrants from the National Latino and Asian American Study. And what you have here is, on the y-axis, the body mass index, right? So a measure of obesity. And here on this side that's closer to me are people who don't report discrimination, and on that side are people who do report discrimination. And you see this uptick, right? So that people who report discrimination are more likely to have higher BMI. And these are very recent immigrants, those who have been here in the US 1 year. Okay, now let's look at immigrants who have been here longer, say 15 years. That slope is steeper. So the strength of association, in other words, one way to say it is that the toxicity of discrimination is worse for immigrants who have been here longer. And in fact, if we add more years in the United States, we see a steeper and steeper slope. So another way we can think about this measure of years in the United States, it doesn't necessarily index acculturation. It can index greater exposure to racial bias. Okay? So the literature on discrimination can force us to rethink some existing measures in novel ways that I think are very important. And certainly, there's been a growing literature trying to connect the experiences of immigration more closely to experiences of race. So there's work looking at, for example, the experiences of primarily Latinos on the border and their treatment by immigration officers, for example. There's work on, say, different dimensions related to immigration, such as whether you're a citizen or a non-citizen, right? So when you think about it, citizenship is one of the fundamental ways that we structure people in society. Being a citizen means that you have access now to rights and obligations that you didn't necessarily have access to when you were a non-citizen. So think student loans, for example, right? And so there are new ways that people are starting to think more deeply about the experiences of immigrants far beyond that of acculturation. Okay. And in addition to a multi-level perspective, I want to think about this across the life course. Okay. So this is some work that comes from Joe Fagan and Van Ostdale. And what they've done is they've done ethnographic observations of children on playgrounds. Okay. And this is one of the quotes from their work, right? No, no, you can't pull this wagon. Only white Americans can pull this wagon. This is a 4-year-old named Renee who says to a 3-year-old named Ling Mai. Okay. And here's another quote. Brittany, who's 3, who says to Talisha, who's also age 3, "You're the same color as rabbit poop. See, your skin is shitty. You have to leave." So children who are very young use many of the same labels that we adults use. And they use their power to segregate sandboxes. Right? And so we need to think about the experiences of discrimination as something that follows people across their entire life course, beginning at very young ages. And one way that we might want to think about this in terms of a picture is this conceptual framework that we developed some years ago. Basically, people are born, right? Children are born. They spend a lot of their early life, close to their families, but as they get older, they go to school, then they go to work, and then hopefully they, at some point, retire. Okay. Now, the blue bar that we have in the middle represents places where we wouldn't want to be, stages where we wouldn't want to be. So that can represent morbidity. It can represent being thrown in jail. It can represent being underemployed or unemployed. Okay. So you would hope that for the majority of us, that blue bar is relatively short. But if your life is interrupted and affected by racism, we might see that that blue bar is much longer. Okay? And in addition, that 10-year gap in life expectancy that your dean mentioned is shown up here in the little red spot, right? So life expectancy is shorter, as well as interrupted by more undesirable places, dealing with things like unemployment or being unfairly thrown in jail and things of that nature. Okay. Now, let me give you some data looking at what people's own experiences of discrimination might look like as they change over the life course. So these are data from the National Longitudinal Surveys of Women. Okay. This is a nationally representative sample of working women. Important features of this data set are that they began in the 1970s and has tracked women for many decades. And so to my knowledge, this is the longest standing data set where we've asked consistent measures of discrimination on a representative sample in the nation. Okay. In addition to asking women about their experiences of discrimination over time, also the NLS, and this is from the Bureau of Labor Statistics, they asked women about different kinds of discrimination. So discrimination based on race, discrimination based on gender, age, and other things of that nature. So if we have prospective data, how might people's reports of discrimination change over time? So if we look at this panel, and these are white women in the sample, the blue line represents women's reports of age discrimination. Okay? So what you see in the very beginning, as they're in their early 20s, that women report relatively high levels of discrimination. It drops in their 30s and starts to rise again in their 40s. Okay? And this is not coincidental. And in fact, EEOC protections start to begin around age 45. Okay? And then as women get into their 60s and 70s, it drops again. And I think the drop is attributable because these are measures of discrimination in the workplace. So I think there's two things happening here. One is attrition, right? So if women are in very hostile workplaces, they're just going to say, forget it, we're going to retire and get out of here. In addition, I think some of these women have assumed great positions of greater authority, and with age comes some gravitas, and so that also accounts for some of that dip. Now, if we look, so that's age discrimination. And again, these are prospective data. If we look at the green line, those are reports of sexism, of gender-based discrimination. And you can see that the shape is actually somewhat the opposite. So it starts relatively low, it rises and kind of peaks in the 30s and then drops again. Okay. So what this really suggests is it's not a question of, oh, are people experiencing discrimination, but it's the nature of the discrimination that they're experiencing will change depending on where they are in their life course. And this is also in relation to where they are in terms of their contact with social institutions, whether your contact is with schools, your contact is with workplaces and things like that. We don't have the data to tease that apart here presently, but I think it's really important to think about how, as we encounter new institutions, those institutions have the opportunity to discriminate against us in new and different ways. Okay. And finally, for the white women, the red line shows reports of racial discrimination, and you can see it's relatively low. If we look at this panel here for black women, you see that reports of racial discrimination are much higher, as you would expect. But also, what's interesting here is that black women's reports of age and gender discrimination look pretty similar to those of white women. So there's some differences in amplitude for sure, but I think these similarities suggest that these are some common grounds from which we can build coalitions. Okay. Now, in taking a life course perspective, it's hard not to pay attention to what's going on today. With all the stuff that's going on with Black Lives Matter and anti-black violence and all that kind of stuff, and we think about children, very young children like Tamir Rice, who were killed. And so in that context, I think we really need to revise our framework from something that looks like this, and when we think of Tamir Rice, to something that looks more like this. Okay. Now, what I've thus far presented is really a story of oppression. Okay? But it's important to recognize the resilience that is also in all of our communities. So as much as we are victims and survivors of racial bias, we are also fighters. Okay? And so there are individual acts of resistance where people are trying to reclaim their dignity, their lives, and things of that nature. There are organized movements where people and communities have fought for each other. There are social service organizations that have risen to provide good services to our communities. And let me tell you a little bit about some qualitative work we did. So these are, we did focus groups with people who were using emergency food services. And they told us a lot of amazing things. And let me give you one of the quotes from one of our participants. She said, "I was in a car accident and I needed prescriptions filled. I dropped over to the city welfare office and this woman treated me like I was scamming something from her. Well, and I'm also on depression medication, and I said, well, look, forget about the painkillers. If this is how you're going to be, just give me my depression medication. Yeah, it would be great to have it because I'm in pain. That's why it was prescribed to me. But if you're going to make a bigger deal about it, then see ya." What this says is that people are willing to forego medications. They're willing to endure pain in order to maintain their dignity and self-respect. And I think these are important things that we have to keep in mind, even while we're trying to understand the role of racism in our society. And let me give you some potentially good news from some work by Doug Almond. Okay. So what we have here is a study of the postnatal infant mortality rates beginning from the 1940s all the way through the 1970s. Okay. And so if we begin with this red line, the red line represents the infant mortality rates for white babies. Okay. And you can see that there's a general decline, and this mirrors general population trends in the improvement of morbidity across many outcomes. Okay. Now, if we consider this green line, the green line basically represents black babies in Illinois. Okay, and there's two important features of this green line. First is this gap between the green and red line. So that's part of the inequity and disparities that we see. We also see that the green line doesn't have a downward slope. It's actually slightly upticking, right? So you could argue that there is a bit of an increase in the infant mortality disparity over time, okay? But if you look after 1965, there's actually a decline. Okay. And if we take a look at this blue line, which represents Mississippi, there's a much greater gap, and in fact, an increasing slope, and also a much steeper decline after 1965. What happened here? What happened in 1965? The civil rights, right? And so, according to Doug's work, we see that civil rights legislation, which was not designed to look at infant mortality, which was designed more generally to protect civil rights, had side benefits, spillover effects in terms of improving health and reducing inequities. So just to close this up, it's important for us as scientists to grapple with the issues of race and racism head on. We need to study this, we need to understand it. Okay. And as we study race and racism, we need to think about the multiple places in our lives when it can happen. We need to think about the multiple systems, where we live, where we are in our access to health care, and all those other things that are important in terms of shaping our lives and all the institutions that we bump into as we move forward. Okay. These are propositions that we need to grapple with as public health practitioners. If all these claims are true, that racism does indeed explain these disparities in health, then what it means at the end of the day is that policies that are designed to protect civil rights are not only important for buttressing the foundations of a just and civil society, but a healthy one as well. Thank you for your attention.